Hello, I'm Puna Woku, the host of our rapid fire round session today. I'm a public health pharmacist and the founder of Health Directorate. HD's mission is to empower everyone to be an expert in their own health and well-being. We seek out experts who are willing to share their best practice, values, and learning points with a wider national and international community. Our motto is connect, share, and create. I am excited to announce my next guest, Paula Lavandeira, on the Pregnancy and Beyond Wellbeing Series Part 2. Paula is an entrepreneur, a fetal medicine specialist, hypnobirthing coach, and a diabetes specialist midwife. Prior to her role as a midwife, Paula was a senior researcher at UCLH, where she was part of a pilot study on the use of non-invasive prenatal testing, which is now available on the NHS. That's one impressive bio, Paula. Thank you for joining me.
Thank you for having me. That's amazing.
I'll move on to my next question. I'll quote a recent study published in December 2018 in the Journal of Clinical Endocrinology and Metabolism, which shows that the exposure of maternal gestational diabetes, GDM, may affect the offspring's body composition, cardio-metabolic outcomes, and time of puberty. Now, in addition to this, NICE, the National Institute of Clinical Excellence, states that miscarriage, pre-eclampsia, preterm labor are more common in women with pre-existing diabetes. Then they go on to state that stillbirth, congenital malformations, macrosomia, birth injury, perinatal mortality, and postnatal adaptation problems, such as hypoglycaemia, are more common in babies who are born to women with pre-existing diabetes. This is quite scary, given that 700,000 women who give birth in England and Wales each year, of these, 5% will have either pre-existing diabetes or gestational diabetes. So my questions to you are multifold. One, at what stages during the pregnancy do women get tested for diabetes? Second, what interventions are in place once they're tested? Third question is, are there any mothers who decline testing? And fourth one is, what is the adherence and compliance rate for good blood glucose control in mothers who have diabetes?
Yeah, that is very scary when you look at the numbers. I always try to calm down the moms because, they might not expect it. But yeah, we can test for gestational diabetes in different stages. So if the mom has had diabetes in the past, depending on what type of treatment and what is the circumstances, we offer them as soon as possible, as soon as they have done their first scan and all is okay. We offer them like a quick one, just to be sure they are not already developing the gestational diabetes, because the sooner we can start helping them to control the sugar levels, the better for her and the baby. But the average is between 24, 28 weeks. That's when we know the body start kind of having problems with the insulin requirements. Depends. The funny things here is that depends on what hospital you booked or you go, you have different approach. So despite the NICE guidelines offer you a guideline, it's up to the hospital how they do it. And it's very tricky for patients because they come all the time, well, in my previous pregnancy, I didn't have to do this. And it's like, which hospital were you before? So they have different type of tests as well. Some hospitals, I remember UCLH follow more the American approach with the hypo, based on the hypo study. And then we follow, most of the other hospitals follow the NICE guidelines with the glucose tolerance test that we do, oral glucose test, we do 28 weeks. So it's a bit confusing for the parents. The thing I always make a lot of effort, and I always kind of go once a month, I do teaching to my own colleagues to tell them, don't be scared of diabetes. You need to start telling patients from the beginning. So what I say is, like, we need to inform the parents when they come in for this test. When we offer the test, we need to explain to them the implications of that test, because most of them think it's a test and that's it, but they don't know the implications of once you've been diagnosed, this is what changed. So if they are prepared for that, they are not shocking. And I probably know that few people will say, no, thank you, I don't want to know, So they can decline if they want. It's an offer, but they probably won't decline if we explain properly all these risks. So what are the implications? What we aim with this test? What is the best for you and the baby? And then they can choose. So it's quite interesting. So if, in my case, what we do, if they have been diagnosed and the test come back positive, then they've been seen by me or my other 2 colleagues that work with me, and we do what we call the home blood glucose test. So they need to monitor the sugar levels while they're at home. The good thing we got now, and I'm very proud, is that we got like a new app. So the patients have the meter connected to their phone, and they can upload the results there. So we as a team can all search for that. So the way we can monitor them and prevent to get worse is reduced. So before we needed at least 7 to 10 days to action that. Now we just can do it in 1 day if we have to. So also I did personal kind of audit with the patient, the mom saying, are you happy with this new app? You know, and the good thing is people who had diabetes in the past and came back with 2nd or 3rd baby, they're very happy with this because they feel independent. They feel like they are in control. So it's very good. The problem we find or we face is the lack of understanding of what is involved with the good level of sugar, you know, or what do we say, the sugar levels, so the blood glucose. But mom is called sugar levels, so they understand better how the body works. And I'm very proactive to explain them in a good way that they can understand. I don't think going very technical helps them. But I always say if they want to be in control, they need to start with the diet. And I don't want them to feel that they've been judged. I just say at the end of the day, you can have a healthy diet, but not from the point of view of diabetes. There are certain things that might be healthy when you're not pregnant, but when you go gestational diabetes, that is like poison for your baby. So you need to change things. And when they understand that, this is very good. They get to that point, and they're very happy with that. What I see as well with this test is that the more we monitoring them, sometimes they make themselves diabetic because if they are not eating well, the readings go high. The doctors say, I'm sorry, the readings are high. This patient got gestational diabetes. So that's why I always insist, what do you want to do? What is the type of pregnancy and labor you want to have? So then you need to work towards that. If you don't do what you're supposed to do, the doctors have an excuse to start intervening. And that's what I see. Sometimes it's unnecessary intervention that I don't think the patients will have to have medication. Probably will be sorted with good exercise and diet, but because they are not doing it, we need to help them because the readings is still high and that can affect themselves and the babies later.
So mentioned at this stage is would probably be metformin or insulin.
Yes, so we try always to approach to be less invasive. So we start with diet, give you all the tips, reduce the carbs, be more active, drink plenty of water, things like that. And then if this doesn't work, we offer metformin. Metformin is the safest in tablets that you can give to treat diabetes during pregnancy. The problem is have a side effect. So some of the moms can't really tolerate it. And then the next step will be insulin. The problem with that is that if you go into metformin or insulin, your pathway of care will change. And that's something that I explained from the first day we got an appointment. So I kind of encourage the mom to do their best if they don't want to be induced, type of thing, or at least if they don't want to have that discussion later on in pregnancy. But yeah.
Okay. So I'll quote another study that was published in February 2019 by Kong et al. In the Journal of American Medical Association for Pediatrics. Maternal insulin-treated diabetes was shown to be associated with significantly high risks for large-for-gestational-age babies and preterm births. So under what circumstances would insulin be a drug of choice over metformin for mothers to be with gestational diabetes?
Normally, I mean, we try always to start with metformin, but if it's late in pregnancy or the readings are really, really high, the choice is insulin because can act quicker than metformin. Metformin needs a few good days, 5 days, to really see the difference. So if you are almost at the end of the pregnancy, the readings are high. And I'm not saying any figures here because some hospitals have different targets, so it might be very confusing. But if the glucose levels are above the targets, that's what we want to, and it's kind of by the end of the pregnancy, the choice is insulin because metformin, the baby will be delivered before the metformin could act. In other cases, if it's at the beginning of the pregnancy, the insulin is also recommended if obviously the readings are very, very, very high. Most of the cases we can do a combination of both.
So what blood sugar reading levels are you aiming for, or should mothers aim for?
In our hospital, we use we want the patients to have readings if it's before, so we check the sugar levels 4 times a day if they are not on insulin, 4 times a day. So the first thing is fasting, so even as soon as they wake up or just before the breakfast, and it should be anything below 5.3 millimoles per liter. If it's after the meals, then we normally check an hour after the meals, so 1 hour after breakfast, 1 hour after lunch, 1 hour after dinner. It should be anything below 7.8 and about 8. So between, normally 7.8. Is very low, or we call that they had hypos, when it's anything below 3.8. So we want in between, let's say 4 and 7.8, that will be ideal after the meals. So if we have a patient who comes with readings of 10, 11, it's like, well, we try first with diets because maybe she's eating things that she didn't know contain carbs. So it's a lot of learning about foods and carbohydrates and how to manage them. If it doesn't work, then depending on the stages and depending on the scan report, see how the baby is, because the moms can already show signs of things like polyhydramnios, a lot of fluids around the baby. So we need to look at the whole picture. It's not just the numbers, it's looking at the whole picture for this mom, and then it's making the decision with them, because at the end of the day, they are the one choosing. But we just say, well, if you go with metformin, for example, it might take a bit longer and you already, but if you already done your diet and you cannot reduce your carbs anymore because you need these carbs as your petrol, it's our energy, then I'm sorry, but we have no choice. I think you should go into insulin. When you explain things like that, the parents are like, okay, fine. It's different approach when you go and see one doctor and say, well, your readings are very high, you need to go into insulin. That's very scary. If you show them what each treatment can offer you and what is the outcome of them, parents are more likely to say, okay, fine. If we got someone who say, well, I don't want to try insulin, I'm really scared of needles, I don't want to do that, okay, we can start in highest doses of metformin, but just to let you know that it's going to take longer.
I think you're starting a new trend here. This is amazing. It's a wonderful
let's
story.
Let's do a mama shower.
Yes, mama shower all the way.
yeah, it's important. It's important. Yeah, and I think we're lacking on that support for moms.
It's a pleasure having you here today, Paula. Thank you for a really great interview. I honestly enjoyed listening to you. Paula Lavandeira. So
thank you.
Midwife, nurse, pharmacist, or allied healthcare professional, and you have any questions or case studies for Paula, then please type them in the comments box below or email me. You can contact Paula on Instagram or on Nurtured Munchkin Facebook webpage. The address will be put on here. Thank you very much for listening.